Okay, today I am going to talk about the NT scan basics and beyond. So, when a patient is coming to you around 11 to 14 weeks of gestation, what are things you are going to look at? First thing is we should look at the number of fetuses, whether it is multiple gestation or single gestation. And if it is a multiple gestation, always ask for the chorionicity. Why it is important? Because if it is, the protocol is going to be different for a DCDA and it's going to be different for MCDA fetus. So, always the number of fetus and chorionicity. Next thing is the dating. If the date CRL is wrong, your double marker mom values are going to be wrong. So, always look at the dating also, make sure it is right. Then aneuploidy screening both in ultrasound and maternal serum biochemistry. Those are the free beta HCG and HCG, PAPA. Then coming to the morphology assessment, just like your second trimester anomaly scan, you are going to do complete morphology assessment in first trimester also. Then coming to the cervix length to rule out the risk of preterm and followed by uterine artery Doppler to find the preeclampsia risk. So, first thing we will talk about the combined first trimester aneuploidy screening. This includes the maternal age, 4 ultrasound markers and 2 maternal serum markers. Let us see the maternal ultrasound markers one by one. And what is the sensitivity of the first trimester combined screening test? It is almost 93 to 96%. If you have missed the first trimester screening, you can go for quadruple marker. The quadruple is the next sensitive test. If you have missed, then you can go for triple, because triple marker test is the least sensitive of all three. Then coming to the double marker test, we as I told you, the free beta HCG and PAPA from the maternal blood we are going to check. For a normal fetus, you are going to look only at the mom values, not the actual values. The mom of these two hormones should be 1. For example, like 1.2, or it can be a little bit above or a little bit below, but it should be around 1. For trisomy 21, it will double, the beta HCG will double and PAPA will reduce. So, you are going to look at the mom, not the value. As I told you, for multiple gestation, for DCDA fetus, they are going to calculate the risk for each fetus separately. Just like a singleton, 2 fetuses they are going to get the risk. For a MCDA fetus, they are going to get the you are going to get the risk for the entire pregnancy. So, you will get the average of both the fetuses NT, and you are going to calculate one single risk for the entire pregnancy. Now, coming to the imaging part. So, as I told you, CRL is the most important thing. This is going to determine the dating till the end of the pregnancy. So, to tell whether the CRL is taken in the proper image, first one is the magnification. You can see only the fetus is occupying the entire screen. So, this is how it should be. You do not include the placenta or the myometrium or anything beyond it. Only the fetus, and the crown and rump should be clearly seen. Then it should be in the neutral position. To tell it is in the neutral position, there should be fluid between the chin and chest of the fetus. I have an annotated image here. So, you can see the first thing you have to see is nasal bone, the rectangular shaped palate, the diencephalon or the thalamus, brainstem, entire spine, bladder and genital tubercle. All these should be seen. You should not see the iliac bone here or clavicle over here or the maxillary process of frontal process of maxilla. So, here is an example of a hyperflexed CRL. You can see there is no fluid here. So, this is a hyperflexed CRL. So, this image is wrong. You should not take like this. This is an example of hyperextended CRL. This is also wrong. So, can anyone tell me whether this is a proper CRL? So, I will tell you the mistakes made here. You can see the clavicle and the frontal process of maxilla. So, this is a slightly oblique image. Next, coming to the first trimester aneuploidy markers, the first one is the nuchal translucency. When are we going to take? Only from the 11 to 13 weeks of gestation, when the CRL is 45 to 84 mm. Beyond 84 mm, always check for the nuchal fold thickness, not the nuchal translucency thickness. So, this is how a proper NT image should be. First thing, only fetal head and thorax should be seen. Do not include the fetal abdomen. And in the head, what are things you are going to see? In this area, 3 lines will be seen. The anterior most line is the tip of the nose, and here we are seeing 2 parallel lines. The above thinner line is the skin, and below thicker, broader, brighter line is the nasal bone. Then in the head region, the rounded first structure is the thalamus. Then these are very easy to remember. I will remember as BIC, brainstem, intracranial transverse and cisterna magna. So the 3 hypoechoic lines you can remember as BIC. Below the cisterna magna, you will see a line, bright line. Below that is the space nuchal translucency between the fetal skin and the nuchal membrane. And how to place the caliper? The caliper should be placed inner to inner or on to on, you can say. This is the correct positioning of the caliper. Do not place your caliper like this. This is another example. While taking the NT, you can also include the intracranial translucency. This is going to be your future 4th ventricle. So if this is increased, then there is a risk of hydrocephalus. So always look at the IT also. Here is an example of hyperflexed NT. This is wrong. Why? Again, it's hyperflexed with the frontal process of maxilla is seen. So this is a perfect image. You can see perfect positioning with all the brain structures and facial structures seen. Here you can take in the maximum region, maximum diameter you can take. Always reduce the gain to avoid the hazy lines. If you enter all the details, your CRL and nuchal translucency in the FMF website, you will get the centiles. This I have already explained you, the nasal bone, 3 lines will be seen. The anterior most is the tip of the nose, 2 parallel lines, the above one is the skin and below brighter line is the nasal bone. Here I would like to tell one important thing. Sometimes we measure the space between the amniotic membrane and the fetus as nuchal translucency. How to avoid it? Always wait for the baby to jump. Once the fetus jumps, the amniotic membrane will not move, but this lines will change. So with that you can identify. Otherwise, start checking from the brain structures. Like below the cisterna magna is the occipital bone. So this is the fetal nuchal membrane, and this is the skin. So this is the actual NT space, not here. This is the space. What will happen if there is a cord around the neck? If there is a cord around the neck of the fetus, then take the NT below it and above it, and you will get an average of it. This is an example of anosphere nasal bone. You can see tip is seen, skin is seen, the nasal bone is not visualized. Next, coming to the next marker is the tricuspid flow. To get this, take the fetal thorax in axial section. The apex should be pointing upwards. Do not switch on color. If you switch on color, you are not able to see the tricuspid valve separately. You keep like this and you can see all 4 chambers of the heart. This is the left ventricle, right ventricle, right atrium and left atrium. These are the atrioventricular valves, the mitral and tricuspid valve. This is the interventricular septum. So you are going to place the caliper over here and make sure that sample size should be more, like 2 to 3 mm, so that it will include all 3 leaflets of the tricuspid valve. Then when you put spectral Doppler, see this is another beautiful image. You can see how nicely the caliper is placed in between the tricuspid valve. You will get a spectral wave pattern like this. So where do we expect the regurgitation? Over here. You have to look for the regurgitation over here along the systole, and you have to increase the PRF if it should be more than 60. Only if the regurgitation is more than 60 cm per second, then you should tell it as regurgitation. Otherwise, it is just a flow of the aortic and pulmonary valve. For example, sometimes we might mistake this as tricuspid regurgitation. This is not tricuspid regurgitation. Why do I say that? See, it's less than 60 cm per second. Also, it has not crossed the systole at all. It's just in the beginning of the systole. So, this is not a tricuspid regurgitation. This is how it should be. It has come around 120 and crossed half of the systole. This is also not tricuspid regurgitation. Coming to the ductus flow, take the sagittal section of the fetus. Only fetal thorax and abdomen should be seen. When you put on color, along the umbilical vein, you will see an aliasing. It will bypass the liver and it will go into the heart. This aliasing point you are going to keep the caliper. The sample size should be less, like 0.7 to 1 mm, and you will get the spectral, this wave pattern. Here this is the systole, the ventricular systole, ventricular diastole, and this is the atrial contraction, S, D and A. Here you have to look. This should never touch the baseline. If it touches the baseline, it's the absent A wave of ductus venosus. It should be like this. It has touched the baseline and there is also a reversal. This is due to contamination from the nearby vessel. You can see the umbilical vein, it has caused contamination. Because of that, it has not touched the baseline yet. So we have completed the first trimester anupladi markers. Now coming to the morphology assessment, you have to do just like your anomaly scan, starting from the head. The first thing in axial section or sagittal, you have to look at the echogenicity and the shape of the skull. It should be proper. Then the central interhemispheric fissure or midline forks, you should extend from anterior to posterior with choroid plexus, two choroid plexus on either side. The space should be more in the anterior aspect. If it is more in the posterior aspect also, then there can be hydrocephalus. Just below it are the thalami, and if you can see the cerebral accurate. The importance of cerebral accurate is it should not go and touch the occipital bone. If it touches, then there can be some posterior fossa malformations. Here how it should be, not like this, it is very close to the occipital bone. This I have already explained you, the brainstem, the intracranial translucency and the cisterna magna, everything I have explained. You can measure the brainstem, it should be less than the space below it. The brainstem occipital ratio should be more than 1. If it is not there, then there is some posterior fossa malformation. Here are some examples. You can see the cranial vault is missing here. So this is a case of acrania, anencephaly, exencephaly sequence. Here you can see a defect in the occipital bone with herniation of brain parenchyma. This is a case of occipital encephalocele. Here we are not seeing the midline forks at all, and this is a fused thalami. So this is a monoventricle, this is a case of holoprosencephaly. This is a case of hydrocephalus with kinked brainstem. This is a case of Walker-Warburg syndrome. This is a case of open spina bifida. You have to document the spine in both sagittal and coronal section. See, this is a coronal section. Next coming to the fetal face. In face, you can take the orbits in coronal and also in axial section. You can see two loosened spaces. These are with internal ring, two rings. This is the orbits. With this, you can rule out anophthalmia or microphthalmia. This is the axial section of the same orbits. This is a case of hypotelorism and hypertelorism. So after that, if you just swipe just below it, you will see a triangular structure over here, that is the premaxillary triangle or retromaxillary triangle, and two echogenic mandibular bones. So I will just explain you this triangle. The tip of the triangle is formed by two echogenic nasal bones. The sides are by the frontal process of maxilla, and the base is by the primary palate or the alveolar ridge. These are the mandibles. You can remember, there should be a mandibular gap and there shouldn't be a maxillary gap. So if you see a maxillary gap, there is a risk of palatine defect. As you can see in the axial, this is a case of bilateral cleft palate. You can see in both axial and sagittal. This is not included in the protocol, but you can just add it. I feel like in first trimester it's easy to see the earlobes. So you can take it in either prone or supine. These are the tip of the earlobes of the fetuses. Next is the frontomaxillofacial angle. It's between the upper surface of the maxilla and the forehead. It should be less than 85 degree. If it is more than 88, then it's a mid-face hyperplasia. Coming to the thorax, two echogenic lungs with a central heart. You can see these four images are enough for fetal thorax assessment. The stomach bubble and the heart apex should face same side, and the two proper symmetrical inflow tracts and the outer tracts, pulmonary artery and aorta, should converge to the left of the spine. These are some examples you can see. These are taken in the trans abdominal plane. in the inflow tracts and outflow tracts. But this is a TVS image, you can see how clearly it is seen with the complete interventricular septum separating it. These are some examples. If you see joining along the posterior aspect, then there can be a crux defect. This is the case of complete AVST. You can see this is a case of Epstein's anomaly. The apicalization of the septum, tricuspid valve with the right atrium is dilated with a turbulent aliasing flow and severe tricuspid regurgitation. Here only one inflow tract is seen, the left tract is absent. So, this is a case of hypoplastic left heart syndrome. Coming to the abdomen, you are going to document both diaphragm on in sagittal view, then abdominal stomach bubble and AC circumference you have to take. This one image will exclude all these conditions. This umbilical cord insertion, you can take it in axial or sagittal view. So, this is a case, you can see the umbilical cord insertion is absent with herniation of bowel loops here, and you can see the sac is intact. So, this is a case of omphalocele. If you are not seeing the sac, it is a case of gastroschisis. This is a case of pentology of Cantrell. You can there will be defect in the anterior mediastinum, anterior abdominal wall, diaphragm, and there also will be ectopia cordis. The heart is also herniating through the defects. Coming to the urogenital system, the kidneys you can take in axial or coronal views. If you are not able to take the kidneys in coronal view or axial view, you can just put on color and document the renal artery. Then the bladder along with either umbilical artery on either side. Here itself we can rule out the single umbilical artery in first trimester itself. If the bladder AP diameter is more than 15 mm, then it can be due to some block along the way of the bladder outlet. If it is around 7 to 15 mm, then there can be due to aneuploidy risk. Then document all three segments of both upper and lower limbs. In first trimester, it is easy to take the open hands because it will be open up most of the time. So, I have taken the open hands here. If you are not able to take the thumb, you can just rotate it your probe to 90 degrees and you will get the thumb also. All three segments of the lower limb along with the foot angle, the leg and the foot should not be should be facing right angles to each other. The foot I have taken here, this is a case of CTEV, you can see the difference. This right limb is fine, but here the left limb, both the leg and the foot are along the same plane. So, this is a case of CTEV. Placenta, just tell where is the placenta location, the cord insertion and how the distance from the internal os. So, for cervix assessment, do the 2D trace, do not use just straight line, always take the 2D trace in transvaginal approach. See, you can see this video, do not give this probe compression. If you are giving probe compression, this will elongate the cervix and it will look like it's an elongated cervix. Also document the lower edge of placenta, how close it is to the internal os and if there is any internal os opening. Uterine arteries you can take from the along from the iliac vessels, or I feel like it's easy to take in the transvaginal approach. Just take the mid-sag section of the cervix and if you just rotate it to the right and left, you will pop it out. This you will get the uterine arteries easily. This is the uterine artery. Check the PI. If one vessel PI is more, then it's okay. The mean uterine PI should not be more. You can put everything in this like website, FMA website. You will get the risk of preeclampsia also. Then document both ovaries, is there any cyst, anything is there, because later it might present with torsion or something, so always document the both ovaries. Then document any fibroids or anything in the uterine wall. Is there any Mullane duct anomalies also you can mention. This is the journal, you can see everything here, whatever I have told you is given in this journal. What are the potential structures you can see and what are the anomalies you can pick. So, thank you so much.